Chapter 8 Mood Stabilizers. This slide summarizes the whole chapter. The FDA says there is no such thing as a mood stabilizers, and the prescribers are like, long live the mood stabilizers. Definition of a mood stabilizer, a labile label. Originally, a mood stabilizer was a drug that treated mania and prevented its recurrence, thus stabilizing the manic pole of bipolar disorder. The term mood stabilizer has become as confusing as it can be wide-ranging. From something that acts like lithium to an anticonvulsant used to treat bipolar disorder to atypical antipsychotic to treat the same. And interestingly, antidepressants are sometimes considered as mood destabilizers. Now a drug can be mania-minded and treat from above to reduce symptoms of mania, or stabilize from above to prevent relapse or recurrence of mania. Or they can be depression-minded and treat from below to reduce symptoms of bipolar depression and or stabilize from below to prevent relapses or recurrence of depression. Let's begin with lithium, the classic mood stabilizer. Candidates for its mechanism of action are various signal transduction sites beyond neurotransmitter receptors, and these include second messengers such as the phosphatidyl inositol system, where lithium inhibits the enzyme inositol monophosphate. Another being modulation of G proteins, and most recently regulation of gene expression for growth factors and neuronal plasticity by interaction with downstream signal transduction cascades, including inhibition of GSK3 and protein kinase C. It is well established to help prevent suicide in patients with mood disorders. Some provocative studies from Austria to Texas to Japan suggest that more lithium mobilized by rains from rock and soil and then dissolved in drinking water, the lower the suicide rates in the general population. Another potential use of lithium arises from the notion that the inhibition of GSK3 could theoretically inhibit the phosphorylation of tau proteins and thus slow the formation of plaques and tangles in Alzheimer's disease. Well-known side effects of lithium include gastrointestinal symptoms such as dyspepsia, nausea, vomiting, and diarrhea, as well as weight gain, hair loss, acne, which might be a problem in females and teens, and tremors, incoordination, sedation, and decreased cognition, which might be a problem during work. There are also long-term adverse effects on the thyroid and the kidney. As we know, lithium has a narrow therapeutic window, requiring monitoring of plasma drug levels. Anticonvulsants as mood stabilizers. Based upon theories that mania may kindle further episodes of mania, a logical parallel with seizure disorder was drawn, since seizures can also kindle more seizures. Anticonvulsants with proven efficacy in bipolar disorders. Valproic acid. Exact mechanism of action is uncertain. Three possibilities exist. The first, inhibiting voltage-sensitive sodium channels, boosting the action of neurotransmitter GABA and regulating downstream signal transduction cascades. The second, that it diminishes excessive neurotransmission by diminishing the flow of ions through voltage-sensitive sodium channels. This may lead to diminished release of glutamate and therefore less excitatory neurotransmission. Another idea is that valproate enhances the action of GABA by increasing its release, decreasing its reuptake, or slowing its metabolic inactivation. And the third being downstream actions on complex signal transduction cascades. Like lithium, valproate may inhibit GSK3. Also proposed mechanisms are blockade of PKC and MARCs and activating of various signals that promote neuroprotection and long-term plasticity, such as ERK kinase, BCL2, and GAP43. It is proven effective for the acute manic phase of bipolar disorder and is commonly used long-term to prevent recurrence. And some experts believe valproic acid is more effective than lithium for rapid cycling and mixed episodes of mania, but often has unacceptable side effects such as hair loss, weight gain, and sedation. Certain problems can be avoided by lowering the dose, but this will generally lower efficacy also, and thus there may be a requirement to combine it with other mood stabilizers. Some side effects may be related more to chronicity of exposure rather than the dose. This includes liver and pancreatic effects, fetal toxicities such as neural tube defects, concerns about weight gain and metabolic complications, and possible risk of amenorrhea and polycystic ovaries. A syndrome may be associated with valproic acid therapy in some women, the symptoms of which include menstrual disturbances, polycystic ovaries, hyperandrogenism, obesity, and insulin resistance. Coming on to carbamazepine. It was actually the first anticonvulsant to be shown effective in the manic phase of bipolar disorder, but did not receive formal FDA approval until recently. It is hypothesized to act by blocking voltage-sensitive sodium channels, perhaps at a site within the channel itself, also known as the alpha subunit. and this action may be similar to OXCARBAZEPINE and its active metabolite. It has proven effective in neuropathic pain as well. Side effect profile includes suppressant effects on bone marrow, requiring initial monitoring of blood counts. It induces the enzyme CYP450-3A4, can be sedating and can cause fetal toxicity such as neural tube defects. LAMOTRIGINE is approved as mood stabilizer to prevent recurrence of both mania and depression. Interestingly, the FDA has not approved its use for bipolar depression, and yet some experts believe that lamotrigine is effective for the same. With growing concern about antidepressants inducing mania, causing mood instability and increasing suicidality in bipolar disorders, lamotrigine has largely replaced antidepressants as first-line recommendations in most treatment guidelines for bipolar depression. Has some overlapping mechanistic actions with carbamazepine, namely binding to open channel conformations of voltage-sensitive sodium channels, but is not approved for bipolar mania as actions are not potent enough at sodium channels, or perhaps a long titration period is required when starting. It is generally well tolerated for an anticonvulsant except for its propensity to cause rashes, including, though rarely, the life-threatening Stevens-Johnson syndrome or toxic epidermal necrolysis. This can be minimized by very slow up titration of drug during initiation of therapy, avoiding or managing drug interactions such as those with valproate that raise lamotrigine levels, and by understanding how to identify and manage serious rashes and to distinguish them from benign rashes. Lamotrigine also reduces the release of excitatory neurotransmitter glutamate, especially if excessive during bipolar depression. This action is unique to lamotrigine. Anticonvulsants with uncertain or doubtful efficacy in bipolar disorder. OXCARBAZEPINE or ESLICARBAZEPINE. It is structurally related to carbamazepine, but it is not a metabolite. It's a prodrug that is immediately converted into 10-hydroxy derivative, also called monohydroxy derivative, and most recently has been named LICarbazepine. The active form of LICarbazepine is the S enantiomer, known as ESLICarbazepine. Pre-assumed mechanism is same as that of carbamazepine, namely binding to open voltage-sensitive sodium channels at the site within the channel itself at the alpha subunit. Some important differences from carbamazepine include being less sedative, having less bone marrow toxicity, having fewer CYP interactions, making it more tolerable and easier to dose. But on the other hand, OXCARBAZEPINE has never been proven to work as a mood stabilizer. But due to a better tolerability profile, OXCARBAZEPINE has been utilized off-label by many clinicians, especially for the manic phase of bipolar disorder. TOPIRAMATE, approved as an anticonvulsant for migraine and recently in combination with bupropion for weight loss and obesity, has been tested in bipolar disorder but with ambiguous results and can cause unacceptable sedation in some patients. Has a different mechanism of action, seems to enhance GABA function and reduce glutamate function by interfering with both sodium and calcium channels but in different ways and at different sites. Is also a weak inhibitor of carbonic anhydrase and is now considered as an adjunctive treatment for bipolar disorder, perhaps helpful for weight gain, insomnia, anxiety, and comorbid substance abuse, but not necessarily as mood stabilizer per se. Is also under investigation in combination with phentermine as treatment for weight loss in obesity. Gabapentin and pregabalin. These anticonvulsants seems to have little or no action as mood stabilizers, yet are robust treatments for various pain conditions, from neuropathic pain to fibromyalgia and for various anxiety disorders. These are now classified as alpha-2 ligands since they are known to bind selectively and with high affinity to the alpha-2 site of voltage-sensitive calcium channels. Blocking these when they are open and in use causes improvement of seizures, pain, and anxiety, but not stabilization of mood. That is, the use-dependent blockade of calcium channels prevents the release of neurotransmitters such as glutamate in the previously mentioned pathways, but do not appear to affect the mechanism involved in bipolar disorder. But many bipolar patients do experience chronic pain, anxiety, and insomnia, and gabapentin and pregabalin may be useful as adjunctive treatments. Calcium channel blockers, L-type. There are various types of calcium channels. L channels are located on the vascular smooth muscles that are targeted by various antihypertensive and antiarrhythmic drugs, commonly called calcium channel blockers. They are also located on neurons where their function is still being debated. Anecdotal evidence suggests that calcium channel blockers, especially dihydroxypyridine type calcium channel blockers, may be useful for some patients with bipolar disorder. RILUZOLE. This was originally developed to slow the progression of ALS. It theoretically binds to calcium channels and prevents glutamate release in an action similar to lamotrigine. The idea being excessive glutamate activity may be occurring not only in ALS but also in bipolar depression. It has been tested in case series in a number of treatment-resistant conditions hypothetically linked to excessive glutamate activity, including not only bipolar depression but also treatment-resistant unipolar depression, and even anxiety disorders with some promising initial results. But is quite expensive and has frequent liver functional abnormalities. Has putative pharmacological mechanism of atypical antipsychotics in mania and bipolar depression. That is, the 5-HT2A antagonist and 1A partial agonist properties of atypical antipsychotics may account for the reduction of non-psychotic manic and depressive symptoms, occurring via reduction of glutamate hyperactivity from overly active pyramidal neurons by 5-HT2A antagonistic actions. This is similar to known pharmacological mechanism of several known anticonvulsants that are also mood stabilizers. And they also increase the availability of monoamine neurotransmitters such as serotonin, dopamine and norepinephrine, known to be critical in the action of antidepressants in unipolar depression. Thus most are approved for mania but only one for bipolar depression, that being quetiapine, with another one having multiple positive clinical trials in bipolar depression, that being lurasidone. Other agents used in bipolar disorder. Benzodiazepines. Not formally approved as mood stabilizers, they nevertheless provide valuable adjunctive treatment, as they can have calming actions immediately and provide valuable time for mood stabilizers with a longer onset of action to begin working. Also, these are quite valuable for patients on as needed basis. Modafinil and ARMODAFINIL. These wake-promoting agents have been tested in bipolar depression with positive results, sometimes classified as stimulants but known to be the blockers of DAT. Hormones and natural products. Omega-3 fatty acids. EPA and DHA has been proposed as mood stabilizer and may also boost the action of proven mood stabilizers. Both have been found in large quantities in the brain, especially in cell membranes. May inhibit PKC similar to valproate. INOSITol is a natural product linked to second messenger systems and signal transduction cascades, and may be an effective augmenting agent to antidepressants in bipolar disorder and in treatment-resistant bipolar depression. L-methylfolate is a centrally active form of vitamin folate and could theoretically boost monoamine neurotransmitter function in bipolar depression. Thyroid hormone, especially T3, may stabilize mood in some patients with bipolar disorder. Antidepressants, do they make you bipolar? These in some cases either do not work or may worsen the situation for some patients who have bipolar disorder, causing destabilization of mood with induction of mania or hypomania, rapid cycling, mixed states or even suicidality. Thus, bipolarity can even be a complication of antidepressant treatment. Currently, use of antidepressants for individuals in these situations must be considered on a case-by-case basis. Thus, treatment of depression in bipolar disorder should start with other options such as lamotrigine, lithium or atypical antipsychotics as monotherapies or in combination. Guidelines do provide use of antidepressants in combination with mood stabilizers, preferring bupropion the most and TCS the least. Mood stabilizers in clinical practice. How do you choose a mood stabilizer? Few patients with bipolar spectrum disorder can be maintained on monotherapy. Studies show that various atypical antipsychotics added to either lithium or valproate enhances antimanic efficacy. First-line treatments in bipolar disorder. When presenting in primary care, in the depressed phase, avoid antidepressant monotherapy, no matter what the current symptoms are. Evaluate if symptoms are due to bipolar or unipolar depression, and if bipolar, use lamotrigine or an atypical antipsychotic or their combination while avoiding antidepressants. Mild mania is not an oxymoron, and some bipolar patients present in this state, which suggests that treatment with either valproate, lithium or atypical antipsychotic, monotherapy or combination may reduce manic symptoms substantially. Combination of mood stabilizers are the standard for treating bipolar disorder. Rather than having a simple regime of one mood stabilizer at high dose and a patient with side effects but who is not in remission, it now seems highly preferable to have a patient in remission without symptoms, no matter how many agents it takes. The doses of each agent can be lowered to tolerable levels, while the synergy among their therapeutic mechanisms provide more robust efficacy than single agents even in high doses. The best evidence-based combinations consist of addition of lithium or valproate to an atypical antipsychotic. Lithium, lamotrigine and valproate can be successfully combined in clinical practice due to practice-based evidence as shown below. Combinations of lamotrigine and valproate need to be carefully monitored due to interaction between the two, especially for the elevation of lamotrigine levels and the possible risk of serious rashes, unless the lamotrigine dose is decreased by up to half. Carbamazepine, although sedating, has less weight gain than many other agents and can be combined with lamotrigine despite relative lack of control studies. Attention should be given to the fact that carbamazepine is an inducer of CYP3A4, which generally means not combining with drugs that are substrates of the same, such as certain atypical antipsychotics including lurasidone, clozapine, quetiapine, aripiprazole, and iloperidone. LAMOTRIGINE combines the two agents with arguably the best evidence as monotherapies. Lamotrigine by itself is a stealth approach, which is augmented by quetiapine, or with any other atypical antipsychotic, for example, lurasidone for bipolar depression or depot long-acting risperidone injectable for rapid cycling. Other drugs as useful adjuncts include agents for substance abuse such as naltrexone, acamprosate, and varenicline, agents for weight loss such as zonisamide and topiramate, and as previously discussed, agents for pain, anxiety, and sleep such as gabapentin and pregabalin, and agitation such as benzodiazepine. And ARMODAFINIL can be combined with atypical antipsychotics or lamotrigine in patients with bipolar depression insufficiently responsive of these agents alone. Boston bipolar brew, named so by proponents who essentially never utilize an antidepressant for bipolar patients. It's any combination of mood stabilizers that does not include an antidepressant. California Careful Cocktail. More laid-back experts propose the possibility of patients earning the right to add an antidepressant, but carefully after exhausting other options. Thus, it's an addition of an antidepressant to one or more mood stabilizers, particularly including one or more that has robust efficacy against mania or recurrence of mania. Tennessee Moonshine. From experts there provide the option of treating bipolar depression that arises when giving an antidepressant and discovering that the patient either has activating side effects or treatment resistance, or the diagnosis is changing from unipolar to bipolar depression. In this case, rather than stopping the antidepressants, an atypical antipsychotic is added. Experimental and off-label combinations include combining lamotrigine with dopamine agonists such as pramipixole or ropinirole. Bipolar disorder in women. They are more depressive in nature than men, with more suicide attempts, mixed mania, and rapid cycling. Augmentation of bipolar patients with T3, both in men and particularly in women, may enhance stability even in the absence of overt thyroid dysfunction. They tend to report atypical or reverse vegetative symptoms during the depressed phase than men, especially increased appetite and weight gain. Comorbid anxiety and eating disorders are more frequent in women and worsen during premenstrual phase. On the other hand, comorbid substance use disorder are more frequent in men. Pregnancy is not protective against bipolar mood episodes, and the postpartum period is very high-risk time for experiencing first onset and recurrence of depressive, manic, mixed, and psychotic episodes. Bipolar recurrence is more common during perimenopause, and estrogen may stabilize mood in these women. During pregnancy, as can be expected, most anticonvulsant mood stabilizers and lithium are associated with the risk for various fetal toxicities. Some may be mitigated by co-administration of folate, and it's more prudent to consider stabilizing bipolar women with atypical antipsychotics during pregnancy. And if mood stabilizers are discontinued for pregnancy, this should not be done abruptly. Decision should be made on an individual basis after weighing the risks and benefits. Breastfeeding while taking lithium is not recommended, whereas breastfeeding while taking valproate, lamotrigine, carbamazepine, or atypical antipsychotics can be cautiously considered while carefully monitoring the infant and, if necessary, getting infant's blood drug levels. Children, bipolar disorder, and mood stabilizers. Prepubertal and adolescent mania do exist and are more common than appreciated in the past. But the symptoms are different from those of classic adult mania. That is, prepubertal mania is characterized by severe irritability, absence of discrete episodes, and periodic affective storms, with severe, persistent, and often violent outbursts of attacking behavior and anger. And as previously mentioned, symptoms tend to be chronic and continuous rather than episodic and acute. And the mood is only rarely euphoric, but there are high levels of hyperactivity and overactivity. Adolescent onset mania may more frequently include euphoria, but otherwise has the symptom characteristics of childhood onset rather than adult onset. Pediatric mania may also develop into adult mixed mania, and pediatric mania seems to have considerable symptomatic overlap with ADHD, and it has been estimated that over half and possibly up to 90% of patients with pediatric mania also have ADHD. In such cases, it is necessary to stabilize the mania before treating ADHD to get the best results, and also combine mood stabilizers with ADHD medication. Future mood stabilizers. These include targeting novel ways of blocking glutamate action or binding to sigma-1 site. Both ketamine and dextromethorphan act at these sites.